Okay, let's unpack this. When we think about healthcare in the U.S., we picture this fortress of safety. But the reality, it's maybe more vulnerable than we like to admit.
Hmm.
Back in 1999, the Institute of Medicine dropped this bombshell report, "To err is human." And the numbers were just terrifying. They estimated between 44,000 and 98,000 people were dying each year in U.S. hospitals because of medical errors.
Yeah, that report really shook things up. It fundamentally changed how we look at safety in healthcare.
And within those huge numbers, they flagged something specific.
Right, preventable medication errors. They figured around 7,000 deaths per year were directly tied to those. Mistakes with drugs that just shouldn't have happened.
And it hasn't exactly gotten better, has it? I mean, I've saw newer data, maybe 2016, suggesting medical errors overall are actually the third leading cause of death now in the U.S.
It's still a massive issue. The scale is staggering.
Which is exactly why we need to do this deep dive, right? We're going to look at the system, the specific rules, and really the vital role nurses play as that final safety net.
Absolutely. And to start, we really need to get our terms straight because it's easy to mix things up. Our main focus here is medication errors.
Okay.
And what that means is a preventable adverse drug event where medication was used inappropriately. Keyword, preventable. These are mistakes.
So how's that different from, say, someone having an allergic reaction? Isn't that bad too?
It is bad, but it's different. That falls under the bigger umbrella term, adverse drug event, or ADE. That's basically any undesirable thing that happens related to a drug.
Okay, ADE is the big category.
Right. And under that, you've got adverse drug reactions, ADRs. These are usually unexpected, unintended responses, even when the drug was given correctly at a normal dose. Like the system worked, the process was right, but the patient just reacted badly.
Okay. So an ADR could be an allergy maybe, or something else.
Exactly. An allergic reaction is one type of ADR that's immunologic, sometimes predictable if we know the patient's history. Then there are idiosyncratic reactions. Those are really weird, abnormal responses, totally unexpected, specific to that individual patient, almost like a genetic quirk in how they handle the drug.
Got it. But a medication error, that means the system messed up somewhere along the line.
Precisely. The system failed. And that leads to the next big point.
Which used to be about blame, right? Historically, if an error happened, the finger immediately pointed at the nurse or the doctor involved. A very painful individual thing.
Oh, absolutely. But those death rates showed that just blaming individuals wasn't fixing anything. It couldn't possibly be that many bad apples.
So the IOM report helped change that perspective.
Massively. It drove home the point that most medication errors aren't because someone's incompetent or doesn't care. They happen because of a breakdown in the medication use system.
The process itself is flawed.
Yes. And think about it. If you blame the nurse every time, what happens?
They probably don't report the error next time. Or the near miss.
Exactly. They hide it. And if mistakes are hidden, you can never fix the underlying system problem that allowed it to happen in the first place.
Okay, so that brings us to this idea of just culture. What does that actually mean in practice?
It means creating an environment where reporting errors or even potential errors near misses is encouraged. It has to be non-punitive so we can actually learn from them.
So people aren't automatically punished for making a mistake.
That's the core idea. Just culture recognizes that, good, competent professionals will sometimes make mistakes. It's human. If the error happened purely because of a bad process, like a confusing screen layout on the computer or a policy that doesn't make sense, the staff shouldn't be blamed.
That sounds ideal.
Yeah.
But I have to push back a little. How does that work when nurses are under immense pressure? Maybe short-staffed, taking shortcuts just to get everything done. Isn't there still accountability?
Oh, absolutely. That's the crucial balance. Just culture isn't a free pass. Staff are held accountable for developing unsafe habits, like consistently taking shortcuts or, deliberately violating clear safety rules.
Okay.
But the institution has to own its part too. It has to acknowledge and fix system weaknesses. And those weaknesses, they're often exactly what you mentioned. Crushing workloads, poor communication between departments, not enough time for training or education.
So the reporting is key. Nurses have to report things even if it feels risky because that's the only way management can see the patterns and fix the broken parts of the system.
That's it. Without the data from reports, the problems stay invisible.
All right, so let's track the medication journey. Where do these system breakdowns tend to happen? There are, 6 steps?
Yeah, the typical flow is procuring the drug, prescribing it, transcribing the order, dispensing it from pharmacy, administering it to the patient, and then monitoring the effects.
Are errors spread out evenly across those?
Not really. The data is pretty clear. About fully half of all preventable ADEs start right at the beginning, at the prescribing stage.
Wow. Okay, so the doctor's order itself.
Often, yes. After prescribing, the next most common point for errors is administration when the nurse actually gives the drug.
And what causes those prescribing or administration errors typically? Is it complex stuff?
Sometimes, but often it's depressingly basic. Things like illegible handwriting on a paper script, if those still exist, misunderstanding abbreviations, or miscommunication during verbal or telephone orders, maybe because things are rushed.
Yeah, I can see that. Which leads us nicely into specific danger zones. You mentioned certain drugs needing extra caution.
Definitely. Two big categories to flag. First, we have the look-alike, sound-alike drugs, sometimes called LASA or salad drugs.
Names that are just too similar.
Exactly. And the risk just skyrockets when those similar names belong to drugs that do totally different things, different therapeutic classes.
Okay, give us some classic examples that trip people up.
Oh, there's so many. Think Celebrex, that's an anti-inflammatory, versus Celexa, an antidepressant. Big difference.
Whoa.
Or metronidazole, that's an antibiotic, versus metformin, which is a common antidiabetic drug. Mixing those up could mean the patient gets no benefit for their infection and potentially dangerous side effects from a diabetes drug they don't need. Or even morphine versus hydromorphone, both opioids, but very different potencies. A mix-up there can be fatal.
So how do systems try to prevent that? Just telling people to be careful isn't enough, right?
Right. This is where system design comes in. A common strategy is using tall man lettering.
Tall man.
Yeah. You capitalize the parts of the drug names that are different to make them stand out visually. So, for example, hydroxyzine versus hydralazine, or Celexa versus Celebrex. It just helps break that visual pattern recognition that can lead to grabbing the wrong one.
Okay, that makes sense. Visual cues. What's the second big category of dangerous drugs?
Those are the high alert medications. Now, it's not that these drugs are involved in more errors necessarily.
But the consequences are worse if an error does happen.
Exactly. The potential for significant patient harm, even death, is much, much higher because these drugs are inherently more toxic or have a very narrow safety margin.
What kinds of drugs fall into this high alert list?
Well, you're looking at things like CNS drugs, anticoagulants, blood thinners, chemotherapeutic agents, certain IV drugs like adrenergic agonists or antagonists. Insulin is a huge one, especially the super concentrated U500 insulin.
You mentioned insulin.
Yeah.
What about potassium? I feel like I always hear about potassium being dangerous.
You absolutely do. Injectable potassium chloride concentrates are right at the top of the high alert list. Giving undiluted potassium chloride intravenously is almost guaranteed to cause fatal cardiac arrest.
Wow.
Yeah. It's why concentrated KCl is often called a silent killer in hospitals. It requires extreme caution, very specific protocols, and often it's restricted, maybe only kept in the pharmacy or specific critical care areas, never on general nursing units as floor stock.
Okay, so we have these inherent drug risks. Let's talk solutions. Technology must be playing a big role now.
Oh, for sure. Technology has been a major game changer in reducing certain types of errors.
Like what?
Computerized prescriber order entry, or CPOE, is a huge one. This replaces handwritten orders with electronic ones.
Which gets rid of the illegible handwriting problem.
Exactly. And it can standardize how orders are written, build in alerts for allergies or interactions, guide dosing based on patient factors. The impact is significant.
Do we have numbers on that? How much does CPOE actually help?
We do. Studies estimate CPOE cuts down the likelihood of a medication error during prescription processing by about 48%.
Wow, nearly half.
Yeah. It's estimated CPOE prevents something like 17.4 million medication errors every year in the U.S. That's massive.
What else? Barcodes?
Yep. Barcoding is critical. The FDA actually mandates it on medications now. Scanning the patient's wristband and then the medication barcode right at the bedside helps confirm the 5 rights: right patient, right drug, right dose, right route, right time. Automated dispensing cabinets, ADCs, also add another layer of control and tracking.
Okay, so CPOE, barcoding, ADCs. It sounds like technology is really solving a lot of these issues, almost like a perfect fix.
Ah, well, that's where we hit the dark side, as you put it. Technology is powerful, but it's not a silver bullet, and it introduces its own set of potential problems.
Like what? How can safety tech cause errors?
The biggest danger is probably complacency. People start trusting the machine too much, maybe stop using their own critical thinking or double-checking things they normally would.
Sort of an over-reliance.
Exactly. And new types of errors emerge. Alert fatigue is a big one. Nurses and doctors get so many pop-up warnings from the system that they start just clicking through them without really reading them. Overriding alerts becomes routine.
I could see that happening.
Plus, the systems themselves can be complex, sometimes slow, increasing workload in different ways, which can ironically lead back to pressure and potential errors. And then there are workarounds,
Ah, yeah. Trying to bypass the system when it feels like it's getting in the way.
which is incredibly dangerous. The absolute cardinal rule with safety technology is never use workarounds. If the system isn't working correctly or seems broken, you don't bypass it. You stop, you report it, you get it fixed. Bypassing safety steps just defeats the whole purpose.
Okay, so technology helps, but vigilance is still key. Now let's talk about some absolute bedrock rules, things that seem simple but cause huge problems like writing dosages, zeros and abbreviations.
Oh, these are non-negotiable. They seem small, but they are responsible for countless devastating errors, often tenfold or even 100-fold overdoses.
So the rules for zeros.
Sacred. Rule number 1. Never use a trailing zero. Never. Writing 1.0 milligram is forbidden because that point year can easily be missed or mistaken, leading someone to read it as 10 milligram.
A tenfold overdose.
Instantly, you must write 1 milligram. No trailing zero.
Okay, and the other rule.
Rule number 2. Always use a leading zero. Always. For doses less than 1, writing 0.25 milligram is dangerous because if that decimal point is missed, it looks like 25 milligram.
A hundredfold overdose?
Potentially catastrophic.
Mm-hmm.
You must write 0.25 milligrams. The leading zero makes that decimal point obvious.
Never a trailing zero, always a leading zero. Got it. What about dangerous abbreviations?
They simply have to go. They need to be written out in full. Using U or U for units is a classic killer. It gets mistaken for a 0, a 4, or even CC, so 10U might be read as 100 units. Huge error.
If you write the word unit.
Always write unit. Another really bad one is Q.OD for every other day. It constantly gets confused with QD, which means daily, or even QID, which is 4 times a day.
Massive difference in dosing frequency.
Huge. So you must write out every other day. No shortcuts.
Okay, that's crystal clear. Let's shift focus a bit to specific patient groups.
Mm-hmm.
Are some people more vulnerable to medication errors than others?
Absolutely. Sadly, pediatric patients are one of the groups most frequently harmed by medication errors. In terms of the risk of actually dying after an error, they're second only to older adults.
That's heartbreaking. Why are kids so vulnerable?
Several factors. Dosing is often weight-based and requires complex calculations. Their bodies metabolize drugs differently, and certain groups within pediatrics are at even higher risk.
Like who?
Kids younger than 2 years old, those in intensive care units, ICUs, any child receiving IV medications or chemotherapy, and this is critical children whose weight hasn't been accurately recorded or updated recently.
And what's the most common type of error with kids?
Overwhelmingly, it's dosing errors. Simple math mistakes in the calculation, or misplacing a decimal point, which, as we just discussed, can lead to massive over- or underdosing.
Okay, so pediatrics is a major area of concern. What about points in the care journey? Are there moments when errors are more likely?
Yes, definitely. Errors tend to spike during transitions of care. When a patient moves from one setting to another, like from the hospital to a rehab facility, or from the hospital back home, or even just transferring between units within the same hospital.
Why is that such a risky time?
Because information gets lost. Medication lists get confused, orders might not be renewed correctly, it's easy for wires to get crossed. This is where medication reconciliation, or MedRec, becomes absolutely essential.
MedRec. Okay, what exactly is that process?
It's a formal procedure designed to create and maintain the most accurate, up-to-date list possible of all the medications a patient is taking. And I mean all prescriptions, over-the-counters, vitamins, herbal supplements, everything.
And this happens at every transition point.
Ideally, yes. It should happen on admission whenever the patient transfers, like to the ICU or a different floor, and definitely at discharge. There are 3 main steps.
Okay, what are they?
Step 1 is verification. That's collecting the information, talking to the patient, family, previous pharmacy, other providers to get the full list. Step 2 is clarification. A pharmacist or other qualified professional reviews the list to make sure the doses, frequencies, etc. make sense, looking for duplications or omissions.
And the third step?
Step 3 is reconciliation. This is where you compare the newly verified and clarified list with any new medication orders being written for the patient, like on admission or after transfer. You investigate any discrepancies. Why is this drug on the home list but not ordered now? Was it stopped? Was it missed? You resolve those differences.
That sounds really thorough, but challenging. What if the patient doesn't know their meds? I take a little blue pill for my blood pressure.
That's a huge challenge. Patients often don't know the names or dosages, or sometimes the list they provide includes drugs they were actually told to stop taking weeks ago. It requires detective work.
We talked earlier about adverse drug reactions, those unavoidable ones like allergies or idiosyncratic reactions. Are we looking for those during meds rec too, or just the preventable errors?
Oh, absolutely looking for those too. Documenting a past ADR, like a known allergy or a weird idiosyncratic reaction, is crucial for future safety. You need that information on the reconciled list so you don't accidentally re-expose the patient to something harmful, even if it wasn't an error the first time.
Got it. Okay, let's shift to the really difficult moment. An error has occurred. Despite all the checks, something went wrong. What does the nurse do, like right then? First steps.
The absolute first highest priority is the patient. Assess them immediately. Monitor their vital signs, look for any changes, ensure their immediate safety. Stabilize them if needed.
Patient first. Always. Then what?
Once the patient is stable or initial interventions are underway, you immediately notify two parties: the prescriber who ordered the medication or the on-call provider, and your direct nursing management, the charge nurse, supervisor, or manager.
Okay, notify a prescriber and manager.
Right. Then you implement any follow-up orders. The prescriber gives maybe specific vital sign checks, lab tests, administering an antidote if one exists. You follow those orders promptly.
What about student nurses? If a student makes an error.
Same principle, slightly different reporting line. The student notifies their clinical instructor immediately. The instructor then helps manage the situation and follow the facility's policy for reporting up the chain.
Okay, now documentation. This feels really high stakes.
Yeah.
How do you document an error?
Very carefully and very factually. The documentation in the patient's chart must be accurate, thorough, and completely objective.
What does objective mean here? No blaming.
Exactly. Critically, you must avoid using judgmental words like error, mistake, or accident in the patient's official medical record.
So what do you write?
You document the facts. What medication was actually administered? What dose? What route? What time? You document your objective assessment findings, the patient's status, any changes you observed. You document that the prescriber and manager were notified, and exactly what follow-up actions or orders were implemented. Just the facts.
Okay, factual, objective in the patient chart. What about the incident report? Is that different?
Completely different. The incident report, or occurrence report, safety report, different places call it different things, is an internal document for the hospital's risk management and quality improvement purposes. It's not part of the patient's permanent medical record.
Ah, okay, so it stays internal.
Yes, you fill it out according to your facility's policy, again, sticking strictly to factual information. And crucially, you should never write in the patient's chart that an incident report was filed. The two documents must remain separate.
That's a really important distinction. Are there places to report errors outside the hospital too?
Yes, for broader learning, there are national reporting programs like the USP Medication Errors Reporting Program, USP-MERP, or the FDA's MedWatch program. Reporting serious errors or trends there helps identify national issues and can lead to wider safety alerts or changes.
This all comes back to the nurse being that final checkpoint, that advocate.
Absolutely. And patients play a role too. The Joint Commission has its Speak Up campaign.
Right, encouraging patients to be involved.
Exactly. Encouraging patients to ask questions, to know their diagnosis, to understand their medications, why they're taking them, what the side effects might be. An informed and engaged patient is another important layer of safety. But the ultimate responsibility still rests with the professionals and the system.
So let's try to wrap this up. If we boil it all down, what's the main takeaway here?
I think the core lesson is that medication safety isn't about individual perfection or heroism. It's about robust systems.
Right, systems like CPOE, like barcoding.
Yes, and implementing a fair, just culture where people feel safe reporting problems. It's about strict adherence to those fundamental safety rules, the zeros, the abbreviations.
And constant vigilance, especially with those high-alert drugs and with vulnerable groups like kids.
Exactly. The nurse is often that last line of defense, catching errors before they reach the patient, but they need a safe and well-designed system supporting them.
Okay, so a final thought for our listeners to chew on.
Well, we've talked a lot about system flaws and the ethical need for reporting and disclosure when errors happen. Institutions are increasingly recognizing they have an ethical and often legal obligation to be transparent with patients, sometimes even offering apologies or support.
Right.
So here's the thought. Knowing the system is flawed and knowing disclosure is the right thing to do. How might professional nurses ethically advocate beyond their hospital walls? Could they push for political action, for legislation that maybe mandates things like just culture principles, safer staffing levels, or universal CPOE adoption, recognizing that those big picture factors fundamentally change the odds of an error happening in the first place? Something to think about.